You're watching Amador County's local television network, TSPN. And now, TSPN News with Tom Slavik. Comprehensive news because in today's world, you need more than just sound bites. Hi, everyone, and welcome to TSPN's News in Depth. And I'm with Dr. Beatty. How you doing, Doctor?
Great, thanks.
Okay, and Paul?
Yes.
And we've talked a couple of times on a couple 8-minute segments.
Yeah.
And so we're going to follow up, and maybe there's a little bit more that we could talk about in the ER.
Yes.
And maybe they'll just come out in what it is we're talking about. You know, the emergency room is probably the epicenter where all the, where it seems the problems that Obamacare, the Affordable Care Act, is trying to address.
I like your shorthand. Obamacare does work, doesn't it?
Yeah, but I think he likes being called Obamacare and all that too, so maybe that's why I didn't. I'm just kidding. But, in all fairness, it's the Affordable Care Act and Patient Protection Affordable Care Act. And right now, today as we speak, we're in the third day of the Supreme Court arguing today about the severability of the mandate. And so we had that yesterday and all that. And there's a lot of stuff that could be said about that. But let's just talk about the emergency room. How long have you been an emergency room doctor?
30 years.
30 years, okay. So I'm going to take you back in history. Was there a time where a person could go to the emergency room and be denied care?
Yes, and that is in fact why I left my previous position. I was working at a number of hospitals where the administrators asked me to stop seeing people who could not afford care. At that time, that was legal.
Okay.
At that time, it was unethical, as it is today. I refused those requests and resigned and came here.
Yeah. As a doctor, I would certainly say it's got to be breaking your Hippocratic oath, right?
It's wrong.
Okay.
Yeah.
So we had a law passed, Congress passed a law and says that you can't deny treatment.
Correct.
And in fact, if anyone goes to a hospital and needs treatment, if you don't provide the treatment, the hospital faces a huge fine. I don't know if
$50,000.
$50,000. I don't know if the doctor faces a fine.
Oh, yes.
Okay. So, so we've got to the point where everybody has access to health care.
Yes.
In that sort of a way. I guess the difficulty lies in then how do you pay for it?
Well, much of it isn't paid for.
And that's why originally people would come on in and you could say, sorry, but we can't treat you because you don't have any money. And
yeah.
I mean, we are a business and, we can't close our doors. So, the administration, probably the hospital's coming down with this policy. Doesn't sound right.
Yeah.
Certainly doesn't fit with probably most people's way of caring for people. And so we have Congress devise this other mandate for hospitals to make sure they take care of people who walk in the door.
That one's called EMTALA.
EMTALA.
Yeah.
Okay, well, great. And obviously that, I don't know what to say, it's got to make you feel a lot better when people come in.
It's the right thing to do, and now it's law.
Right.
That's
and a good thing about it to us is that why people, I think, love our healthcare system is, you're not making any decisions other than how do we make this person better.
The best treatment is what you ought to get.
Right. And, I love that. I mean,
yeah.
I love knowing that, in my country or wherever, that anybody that's hurt, we don't look at you as anything but a hurt person, and we're going to fix you up.
Right.
Get you everything you need, all the tests, everything.
Yep, you need an ambulance, you need an ER, you need surgery, it's all there.
Okay. Now, at the end of that, though, people still have to come up, even today, if they go in there and they have access to health care, but they don't have money.
Yeah.
Maybe, maybe they have assets and things like that. So the hospital, I believe, has ways of trying to collect payments for that, right?
Yes. And we do some of that. We also do a great deal of charity care. We write off a substantial part of our business because the patient doesn't have any money and there's just no point in pursuing them. So in those circumstances, we just figure that's a bad debt and let it go.
Okay. And how about other ways that people can access the health care, too, that don't have money? Meaning, like, I believe in California here, we call that not Medicare, but Medi-Cal.
Medi-Cal.
Okay. What happens with a Medi-Cal patient that comes in, and how does that work?
It's very difficult right now. The state's in so much financial difficulty that Medi-Cal reimbursement is quite low. A number of docs in town have decided that they just can't deal with Medi-Cal anymore. There's a lot of refusals for service, the reimbursement's low. Some docs have even said, it costs me more to send out the bill, the Medicare, than I get back in payment. Quite literally, sometimes when we see a patient in ER, we'll get paid $12 or $20 for the visit. Not a whole lot of money. But given our ethical obligation to see everybody, we accept Medi-Cal and will continue to do so.
Okay.
It's troublesome that they don't pay very much, but so it is. I can't change that.
The interesting thing is last night I heard that basically that is, the cost shifting that we heard yesterday at the Supreme Court was mentioned quite a lot, and they were trying to point out that actually the cost shifting is more because of Medi-Cal than people coming in for emergency, because Medi-Cal is essentially where doctors do try to come up with adjusting and making those things, adjusting out that payment. So the people that have insurance rates probably go up. Also, the Medi-Cal kind of describes to doctors kind of what they can charge for certain things, right?
Actually, Medicare would be a better standard for what you can charge.
Okay.
I think everybody sees Medi-Cal as pretty substandard, but Medicare is a much easier thing to endorse and to get your arms around, because we all understand that we're going to take care of old folks and that we're going to give them a break and that we're going to make it easier for them to obtain care. So in Medicare, it's easier to feel good about that level of service. And the reimbursement is, unlike Medi-Cal, which is just flat poor, Medicare is fair. It's decent.
Okay.
And it's a level at which many of us feel pretty comfortable.
Okay. Now, let's see. I brought up saying, the ER room is probably the epicenter. That's where people come in. Now, Sutter Amateur Hospital is increased the size of the ER. Has that to do with anything where you're looking down the road at the future saying,
yes,
we're probably going to have a lot more need?
It's our job to meet the need, and when you're talking about real estate, you have to build before you need. And so we saw a probability that we'd see more patients. The other thing that increased our awareness of that is we're seeing increased number of patients, partly because patients want an emergency room environment, they like immediate access to care, partly because we're pulling patients from outside communities into our community because our ER runs better than those around us. It's popular with patients. It's well thought of. That helps a lot. So there were several things that led us to think we need more room because this is likely to grow.
Okay, we have a few more minutes in this segment. Now, with the Health Care Act, if that goes through, now will we have, yes, right,
yeah.
Its legitimacy right now is being questioned at the Supreme Court.
Yeah.
Now, well, is that the best place to care for people at the emergency room?
No, it is not. It certainly is not. There are many things that are handled better in a primary care environment. Right now, there's a significant shortage of primary care doctors. That will get worse if we pass the Affordable Care Act. All I can do is adapt to that. I'll provide care in the emergency room. I don't have enough time to open a family practice, but if I did, it would be a good thing.
Okay. Now, are there problems right now that you're addressing at the emergency room for also, to get over the hurdle of probably a lot more patients coming in to see you at the hospital, in the emergency room, or wherever?
Yes, and a couple of those hurdles relate to trying to build new rooms to see patients in as quickly as we can. But I think we've got that under pretty good control. The next piece of that puzzle is we have to have more practitioners available, and we have to understand how we're going to organize ourselves. And that's something that we're working on right now. We've just started a new process looking at a radical change in the way patients are brought into the department that will let us see patients in a much friendlier and faster fashion. And I think that's going to really allow us to step up our level of care for people.
Okay, and that sounds like a good plan. We've talked about that a few times during our interviews. I have one more minute left, and maybe I'll try to tease it a little bit.
Yeah.
Now, with the Obamacare, to pay for it, it was supposed to come in at like about $900 billion.
Big number.
It came in a big number, but this, the CBO addressed earlier this month that it's costing twice that amount. So it's coming in at $1.8 trillion. So it's costing quite a lot more money. And part of that was because of the way it was sold, so to speak, or the numbers that the CBO had. And with that number, there was a, as most people on Medicare know, there was a $500 billion taken from Medicare and put into Obamacare. So when we talk about, what you think about this, when we talk about in depth, Tom Sliver with Dr. Paul Beatty. How's it going again, Paul?
Just great.
Okay, now we were talking about Medicare, and I couldn't get that word out. Maybe we cut that senior moment. I think as a senior, and as talking to seniors, and even looking at the whole problem, taking that much money out of Medicare isn't that going to hurt Medicare?
Yes. Yes, it will. However, part of what this plan hopes to do is level the playing field. Right now, Medicare and its patriots are well reimbursed, or at least moderately well reimbursed. You can count on being able to find a doctor that will take care of you. A lot of poor folk and a lot of working poor folk don't have any coverage at all, and we carry those folks. Part of what we hope, or what's hoped, is that this plan will shift some of that insurance money to these people so that everybody has some coverage.
Okay, now it's very interesting because what you just said, I know it's true, maybe not to level the playing field, whatever, but at the Supreme Court yesterday, all the talk was about the problem that they were having and who they were trying to get into having to buy the insurance were the young people.
Yes.
Who don't need it, or feel they don't need it. It's something they don't have to pay for, or until they get sick. But then they're also saying, why not just catastrophic? When I get sick, let me get that. I can get an insurance policy that covers me getting sick, but maybe I'm not worried about coming out with a stroke and a heart attack right now. I feel pretty healthy, and I'd rather use the money to buy a house, whatever. And, I guess we can make an argument, well, this is more important, but it's America. You basically should be able to choose where you're going to spend your money.
Free country.
Okay. Now, I didn't bring it up to make that point. What I brought it up for was that's what the Solicitor General was basically saying. We need these people in here, because when we get these people in here, then we can drive down the cost. And the court's saying, but you're making people buy stuff that, not only that you're making people buy stuff, but they don't need that stuff. You're actually trying to get those people in the pool to make your plan work.
That's correct. It's like car insurance. We insist that everybody
carry that. But I wanted to go back.
That
is the people that are trying to be put in the pool. It's not the, as you said, the Medicare or the Medi-Cal, that should be addressed, but we don't have money for that. I'm not sure why we don't have money for that, but that could have been addressed in another way. In fact, that's part of the arguments on the side of Obamacare being illegal or unconstitutional, which would render it illegal, is that it doesn't. It had other ways to address the problem that indeed would be constitutional, and so this can all go back to Congress and they can fix the problem.
Certainly that. If we elect a Republican Congress, I think a move in that direction is likely, particularly if we have a Senate majority on the Republican side. I think we'll see a move in that direction. Again, if we elect a Republican president, I think we'd move in that direction. I think that we need an answer.
Okay, I didn't really intend to have you and me on this get into the political part of it, but
it's all entertaining.
Being today, and where it is, because we're discussing something that I'm not going to say it's going to go mute. We still have sick people. We still have the hospital's going to have the need for those people. It's how it gets paid for, how it works out.
Yeah,
it's probably best left to the legislature, and so we can get back into your field.
Yeah.
Okay, and we were talking about and I guess I'm going to have to go back in here again. We were talking about Medicaid, and me as an older person, I'd like to know, like, when you say equal the playing field, it scares me a little bit. If I need a hip, right now I'm 65, I suppose I need it when I'm 80, am I going to be able to get a hip replacement, or is I'm going to say, Tom, you're probably too old, we need to give that money to, those people on the Medi-Cal side who are younger, and they need something that would work better for him. Sorry, but, it's time that we even the playing field and we look at you and say, just no money.
No, that's not going to happen.
Okay.
The ethics of this are that we need to improve the level of care, not diminish the level of care. That's what we need to do.
But we have the iPad, the independent panel that's going to have 15 people that aren't answerable to anybody. Mm-hmm. Once they get put in, it's basically, they don't answer to Congress. They don't, So, and they're the ones that make the decisions. I've heard doctors say that, especially say from your perspective, if a person comes in and they might need have a stroke and they need this operation going forward in that, and they have to book it, we have to get the iPad's permission, or at least we have to look at their policy that we haven't seen yet as to what are all the factors that are going to go in. Right now, it doesn't matter. I could be 105 and you'd be giving me the best care in the world. But what would happen if that's not the case with the policies from the iPad?
The iPad is not a mechanism to deny care. The iPad is a mechanism to try to make some sense out of the technology that we have.
I believe it was to control costs.
Right, because we have some ridiculously expensive, ineffective therapy out there. There are some things that we can do that just don't work, and they're horribly expensive. We should stop doing those. For example, I'll just give you one toss-up.
Okay.
Bone marrow transplants. They work in leukemia. They're not too bad in lymphoma. They don't work in breast cancer. We know that. We've seen the statistics. All it does is kill people. We should stop doing that. That's where the iPad's going to be useful. Not to deny care, but to put the dollars where they're going to do some good. I think that's what it ought to be. These people need to be nearly gods. They need to be really effective, really smart, really educated. It's going to be hard to pick these people, but we need to pick them.
So you're basically describing a mastermind, and these 15 people will be masterminds.
I'd rather say council of elders. I'd like some really smart people.
That sounds like maybe what Plato would have called them.
Right. I'd like judges. I'd like retired nurses and teachers.
Plato was arguing for a utopia.
I want a utopia. It'd be a great place to live, wouldn't it?
We've never had a utopia, and utopia is just a promise down the road.
Yeah.
What we have had is a really great country with people able to make their decisions and base them on work, their work ethic, the ability to have private property, money, pass it on, give it to charity, help people out.
I like all of that.
Okay. So, now, where do we go from here?
Well, this is a socialistic impulse. Trying to get everybody insurance and medical care is a socialistic kind of idea that is a good one because it'll make the country stronger.
It could be done with a single-payer program.
Yes, it could.
Right? Which is, once again, there was another way that it could have went.
Maybe a better way.
I believe it didn't go that way because there wasn't the political will.
Agreed. And yet, there's enough practitioners that would support that idea that I think they could have pushed it. The problem with a single-payer program wasn't the physicians, it's populace.
Would you, you're describing kind of you opening your philosophy to me, would you want all doctors to be paid equal?
Nearly. Now, there's quite a bit of difference from one doc to the next in how hard they work, how long they stay up, how many patients they see. I'd like to reward that kind of behavior. But right now, there is a serious disparity between what we pay a family practice doc and what we pay an ophthalmologist.
And isn't that basically based on the free market system?
It is.
Now?
Yes. Yes.
And you find that
acceptable? Yes. The best way? No. No. I'd like to see a little more level playing field. I think we have a crying need for family practice, but it's not very well reimbursed, so people don't go there. The market works.
Okay, the market works. I'm trying to come up with some analogy here, and I don't know if there is one. I think basically you're putting forward your philosophy.
Yes, sir.
That is, utopian philosophy, as opposed to
It is.
John Locke, and the founders that basically we have a free market system.
I like that.
Free market system works. It gives competition. I'm not sure if your system would provide competition to bring costs.
Oh, it does.
And give people new. What would cause that?
Well, I'll tell you about what we do in the ER. We pay based on performance, on market. If you work hard and see a lot of patients and do a lot of work, you get paid more. If you don't work very hard and don't see very many patients, you get paid less. It's a real simple system. I like that system, and I think it's a good way to go. It could be used much more widely in medicine. In particular, I think you have to help people who do things that aren't paid very well right now.
But you would have different. You would need what, an administrator to look at all these things. Maybe the person doesn't want to work as much as that other person because he's put in a lot of years.
It's okay, pay him less.
Does he get paid the same now?
No. In our system,
doesn't it basically get paid on what work he does, or how much the?
You get paid on what work you do, not what hours you put in, but how much work you actually accomplish. And I think that's a powerful tool, because our docs vary quite a bit. Some of them are really fast and really strong.
And people do vary quite a bit.
Yes,
I mean,
they do.
we have we have athletes that, $2 million, $3 million, $4 million contracts, and they get that because
they're really
you can't
good.
find a better athlete. If
That's
you
right.
could, he'd be making the money.
Right.
So, very, very talented doctors should
make more.
Make more. How much more?
I think 2 to 1, 3 to 1 is a reasonable ballpark.
Okay. Well, we have to go, but I think it was interesting because, I mean, the free market, the person buying the service or the person getting the ball player for the team trying to sell the tickets gets to decide. And the other way, we have somewhere a mastermind that's deciding what is good and what's fair and appropriate for payment.
We should look for balance.
Okay. And we'll leave on that word. And thanks for watching News in Depth today with Tom Slavic and Dr. Paul Beatty. Thanks, Doctor.
Sure, it's been a pleasure.
You had a good time.
Yeah.
Thank you.
Yeah.